Hello, all wonderful learners out there. So, we are again back today with something very special and a special series which I have started, that is case based learning. Now, you know that case based learning is a part of your curriculum, that is when you are doing ECE, that is early clinical exposure, and also you get an SAQ, you get an LAQ where a clinical case is given to you. You have to diagnose the case and you have to find out the related answers which are given to this. So this is going to be a case based learning session where I will be taking as much as possible clinical cases and related questions to it. So I welcome you all on Dr. Reena's Physiology Conceptual and Integrated with my Telegram group Physiology Synapse to Success, where I give notes for whatever classes I take upon, right? So let's get started to the case today. Now this is the case of a 36-year-old woman who comes to gynecologist with complaints of amenorrhea, hirsutism. She has also noticed an increase in her weight, which is especially in the truncal region, and she notices easy fatigability, right? And she denies any medical problem. That means there is no significant medical past history to her. Her periods are normal until 6 months ago. She finds that the hirsutism has been gradual in onset. On examination, she has got a rounded hirsute face with a centripetal obesity. The blood pressure is elevated and the weight is also more as compared with the previous visits, right? So you get a very typical history. What is the most catchy point over here? Moon-like face, that is a central rounded face with a centripetal obesity, amenorrhea, and she is gaining weight as compared to past. Now on abdominal examination, she has got a striae and a male type of a distribution of hair in the lower abdomen. You know that the male and the female distribution of hair is totally different. Looking into these symptoms, I am now putting certain questions to you. Diagnose this patient, right? The hormone that is responsible for this medical condition comes from which endocrine gland, and enumerate the important functions of the above hormone. In many cases, the diagnosis may be provided to you and you may be asked to give some other answers to some other questions. But here you can see you have got a very typical history. Striae, abdominal striae, centripetal obesity and gaining weight with a female who is also developing hypertension, hirsutism and amenorrhea. So these are very significant and very condition that take you towards an excess of cortisol, especially when there is a central obesity, right? When there is a central obesity and there is hirsutism. So this is very classical. So let's summarize this and let us try to find out the answers of the above questions. So to summarize, this is a 36-year-old woman with amenorrhea, with hirsutism, with elevated blood pressure, abdominal striae, weight gain, and she is having Cushing syndrome. So what is Cushing syndrome? It is an excess of cortisol. It is an excess of cortisol. And if you don't diagnose the condition properly, तो आप क्या करोगे? Hormone में भी गड़बड़ कर दोगे. Very common mistake, you can think that this is myxedema and you may just write everything about myxedema and about thyroid hormone. This is the common mistake which is done at the level of the first MBBS. So diagnosing the condition is possible only if you are able to verify the clinical condition or the clinical clue that is given to you. So please be very vigilant when you are studying endocrines, because it is a very important concept which will take you more and more perfection towards your clinical medicine as you move with your second and final prof. Now you know that cortisol production is coming from the adrenal cortex and it is coming specifically from zona fasciculata. So just looking upon to few theoretical points, you know that the adrenal cortex or the adrenal gland, so this can be a 2 marks BAQ that there is adrenal gland. So I can give a 2 marks BAQ to you, that what are the secretions of the adrenal gland. When I am saying adrenal gland, please remember I mean medulla and I mean cortex both, because most of the times when I correct the answers, I have seen that medulla is totally lost out somewhere. So it is the medulla that is secreting catecholamines, which is epinephrine and norepinephrine, and the major hormone that is coming from the medulla, that is 80 to 85% is your epinephrine, whereas norepinephrine is 10 to 15%, and norepinephrine is a neurotransmitter. Epinephrine is not a neurotransmitter, very important point. When we consider adrenal cortex, it has got 3 layers, GFR, that is zona glomerulosa, fasciculata and reticularis. A very important MCQ, which layer is maximum? So it is zona fasciculata, which is around 50%, around 21 to 28% is your glomerulosa, and the remaining around 7% comes to your reticularis. The principal secretion of fasciculata is glucocorticoids, of reticularis is androgens, and of glomerulosa is mineralocorticoid. The chief mineralocorticoid is aldosterone. And again, important MCQ, what are the secretions of androgens? They are not testosterone, they are dehydroepiandrosterone, right, and androstenedione. So the secretions from the androgens, or the androgens which are coming from the reticularis, is not testosterone, it is dehydroepiandrosterone and androstenedione. Androstenedione and dehydroepiandrosterone, please mind this well. Now, what are the very important principal functions of cortisol? So I have just highlighted the points, but if it is an LAQ, you will have to cover these points, writing at least 4 to 5 or at least 2 to 3 sentences about each point. One important thing, it is called as a stress hormone. So if you get an MCQ, which is the stress hormone, the first correct answer will be cortisol. Second important thing, it is a hyperglycemic hormone, that is one of the hormones which increases the glucose level. Others are, quickly recap, others are catecholamines, glucagon, right, catecholamines, glucagon, thyroid and your growth hormones. So I repeat, growth hormone, catecholamines, glucagon, cortisol, thyroid, they are all hyperglycemic hormones, and the only hypoglycemic hormone which is present is insulin. So among the principal functions are increasing the blood glucose level, that is gluconeogenesis. It is catabolic in nature and therefore proteolysis. Lipolysis with a centripetal deposition of fat. That is the very important peculiarity of cortisol. It is centripetal or a truncal obesity. Decrease in the glucose utilization and therefore making glucose available for the vital organs, especially heart. And heart is never deprived of glucose even if there is presence of cortisol. In decrease in the insulin sensitivity, because it causes a decrease in the insulin sensitivity, it is supposed to be a diabetogenic hormone. It is supposed to be a diabetogenic hormone. Which is the other diabetogenic hormone? Remember, quick, it is growth hormone. Then it is anti-inflammatory, it is immunosuppressive, it is anti-allergic because it is inhibiting your immune functions. You can remember, it decreases BEL. What is BEL? Basophil, eosinophil, lymphocyte, whereas it increases your RBC, neutrophils and your platelets. That is cortisol. Another important function is increase in GFR, inhibition of the bone formation cells. So it prones the body more to osteoporosis, right? It prones the body to osteoporosis. It has got a very, effect that it increases the increases the responsiveness of the body to catecholamines. So this is called as a permissive action of cortisol. A permissive action of cortisol, where it increases the effectiveness of the body or the response of the body to catecholamines and also to glucagon. So this is a very important INICT kind of an MCQ, that it is permissive for catecholamines and glucagon. And Later on you will study what is REM sleep, rapid eye movement sleep, which is also decreased by cortisol. Now, where is hypersecretion of cortisol is Cushing syndrome. Remember, when you study your cortex, you will get Conn syndrome, which is hypersecretion of aldosterone. So this applied has to be studied nicely. So Cushing syndrome is excess of cortisol. This cortisol can be because of different reasons. How? This cortisol can be either because of excess of cortisol coming from the adrenal cortex itself. मतलब एड्रिनल कॉर्टेक्स का कोई ट्यूमर है और इस वजह से कॉर्टिसोल बढ़ गया, या it could be because of increase in the ACTH. Suppose there is pituitary adenoma, so pituitary is causing increase in ACTH, that is causing increase in cortisol. Or sometimes it could be ectopic ACTH, that means ACTH is coming from some tumors and that is causing Cushing syndromes like features. So cortisol secretion hyper excessive can result in Cushing syndrome. Very characteristic features which you must keep in mind when you are writing an answer is hyperglycemia, central obesity like buffalo hump, moon like face, muscle wasting, abdominal stria, hypertension. These are the conditions that you must not miss out, osteoporosis and hypertension, because these come as 2 marks BAQ. Enumerate 4 clinical features of cortisol and you are done with the answer. So you can see over here, this is what is a picture looks like a patient with Cushing syndrome with a central moon-like face, a buffalo hump. This is the abdominal stria because of the breaking down of the collagen in the skin. So like of stretch marks, but these are not stretch marks, purplish stria are there, right? Now, next important thing is very interesting is what is dexamethasone suppression test at the edge, you must know. So what is dexamethasone? It is an exogenous steroid that mimics negative feedback of endogenous cortisol. So if you remember your cortisol, how is the feedback? This is the cortisol which is coming from the adrenal cortex, which is coming by stimulation of ACTH, which is coming from the anterior pituitary, and ACTH is under the control of CRH, corticotropin releasing hormone, coming from the hypothalamus, and the regulation is by negative feedback mechanism. So this dexamethasone, it is an exogenous steroid that is going to mimic the negative feedback effect of endogenous cortisol. So if you give cortisol, what is going to happen? So, right now, this is called as a dexamethasone suppression test, which can be given with a low dose or with a high dose. Now there are different conditions. Suppose cortisol is produced from the adrenal nodule. जैसे आपको मैंने बताया कि suppose adrenal nodule है और वहाँ पर adrenal tumor है जो cortisol को बढ़ा रहा है. तो अगर cortisol पहले से ही बढ़ा हुआ है, if already the cortisol is high, this itself is going to inhibit ACTH through negative feedback mechanism. This we know कि अगर cortisol पहले से ही बढ़ा हुआ है तो ये ACTH को suppress करेगा through a natural negative feedback mechanism. और इस condition में अगर आपने dexamethasone दिया तो कोई भी फर्क नहीं पड़ने वाला, because ACTH is already suppressed. So very clear, अगर cortisol is coming from the adrenal medulla, ठीक है, और अगर आपने डेक्सामेथासोन दिया तो वो डेक्सामेथासोन ACTH को इनहिबिट करने में इफेक्टिव नहीं होगा, बिकॉज बॉडी में ऑलरेडी इतना सारा कॉर्टिसोल है कि ये ऑलरेडी ACTH को इनहिबिट कर रहा है. तो ऐसे क्लिनिकल कंडीशन में इट इज़ वेरी क्लियर कि डेक्सामेथासोन सप्रेशन टेस्ट से ACTH को कोई भी फर्क नहीं पड़ा. दिस मीन्स ACTH was already suppressed and that suppression is caused by the cortisol that is coming from the adrenal medulla. सेकेंड, आप करते हैं लो डोज ऑफ डेक्सामेथासोन जैसे 4 मिलीग्राम्स. इसमें इस कंडीशन में दिस विल नॉट सप्रेस इफ इट इज एन ACTH producing adenoma, right? So if it is an ACTH producing adenoma and you give a low dose dexamethasone, again it will not suppress. But if you give high dose dexamethasone, then it is going to be suppressing, because अभी क्या हो रहा है, this ACTH is coming from the adrenal adenoma. Finally, if it is an ectopic ACTH secretion, ectopic matlab it is not coming from the pituitary or it is not related to the adrenal gland, but it is because of some tumor. ऐसे conditions में अगर आपने dexamethasone दिया, it cannot suppress cortisol secretion. Even high dose will not suppress and even low dose will not suppress, because इसमें जो आपका excess of cortisol हुआ है, that is coming from ectopic source of ACTH. That means यहाँ पर the source of ACTH is not adrenal cortex. It is ectopic, that is apart from adrenal cortex. So dexamethasone primarily helps you to come to a conclusion that this excess of cortisol is either because of tumor coming from the pituitary or the tumor coming from the adrenal gland, or it is ectopic, right? So this is dexamethasone suppression test. So this is done for the day. I always say that you study, but whenever we are studying, there are lots of negative thoughts which come into our mind, and I have realized that the mind is actually a magnet. And if you think of blessings, you will attract blessings. If you think of problems, you will attract problems. So MBBS, may you take admission, you are super excited, but as you keep on studying, you realize that the things are not so easy as we thought. But try to cultivate positive thoughts in the mind. One of the very important approach as a medico is positive optimistic thinking. Positive optimistic thinking. This is a glass which is half filled. People say, oh, it is empty. People say, oh, it is half filled. But I am an optimistic person and I say, thank God, at least I have a glass, because if I have a glass, I can put water into it. So life is a blessing. Protect yourself from negative thoughts. Please help to share this physiology to one and many. And God bless you all. Thank you.